What's up, everyone? Welcome back to the Critical Care Lounge. I'm here with my always handsome, always debonair, Adam Green. What's up?
Not much, man. How are you doing today?
Oh, awesome. What is that? What is that you're wearing? It's a what kind of shirt is that?
Headset.
No.
My
A little
shirt. My
lower. Let's
shirt.
see what's below the
Well, I
chin.
got to stand.
Oh, look at that, everybody. If you know, you know. James Harden, the beard, is the 76er. Are you sad or happy about that?
Well, obviously happy. I bought a shirt.
Is doing really well too. And how's
Yep.
Ben Simmons doing for that trade? Is he playing yet?
You know, my favorite
my
my
back.
favorite thing was the article that immediately came out talking about how great of a teammate James Harden is.
Mm-hmm.
You know, and it's
Yeah.
I still think it's a time bomb waiting to explode. But you know, let's jump on board while the ride's good, right?
Listen, if there's one thing the Phillies fans are not, it's subtle. They will let you know. And so I think everyone wants. I think Ben Simmons is due to come back on March 10th, and everyone's praying that this back pain that he just instantly had goes away, so he can come and they can give him their fair share of their.
That's right.
Anyway.
That's right.
Let's not delay this episode. I'm so excited for it because for the first time in Critical Care Lounge history, I'm going to sit back and relax, and you are going to host with a very special co-host. Is that right? Do you want to go ahead and
That's
introduce
right.
him?
Boss man, Nathan Puri. There he is. So I get to introduce you, and I've been thinking long and hard as the words I was going to use. So the way I would describe you, Dr. Puri, as
Careful.
a pulmonologist at heart, the best boss I've ever had. Keep in mind, you're the only boss I've ever had, and an outstanding critical care physician. So I can't wait. With that said, tell me, who do we have? Who do we have with us?
So who we got with us today is the reason that I went into critical care. The man himself, a legend. I believe Haney used which is not oral gastric tube, but original gangster. My father, who is really an inspiration to me and has been to many critical care physicians. So, Papa, thank you for joining us tonight.
That's great. Thank you so much.
Thanks for the compliment, but I tell everybody I never encourage you to go into critical care. So it's your own doing.
What would you have had him do?
Well, he actually tried nephrology, I guess. He didn't make it. So,
there you go, man.
So Phil Dillinger took pity on him. I think he took him in.
That's right.
It's turning into a roast.
That's great. So I would love to hear a little bit about your career, and I believe you started your training in India. What you trained in when you came in India, and then when you came to the United States. Walk me through how you kind of your path to becoming an intensivist.
Okay. Well, I was already a trained general surgeon when I left India. We had a degree which was called Masters in Surgery, or MS. And then I did the usual 5 years of general surgery all over again. Our first year used to be, in 1969, a rotating internship. So you get around to, delivering babies and everything. So I got a little flavor of other things. And after finishing my residency, I wanted actually to be a trauma surgeon, but the trauma surgeons in Detroit, the famous receiving hospital, were rather afraid to take on a fully trained surgeon because they thought that there'll be a conflict of interest with their senior residents. So I took a fellowship in critical care. There were only two programs at the time, 1974. One on the West Coast, Max Harry-Weil at University of Southern California, and the other at University of Pittsburgh. So I ended up in Los Angeles, leaving Detroit, and did 2 years of fellowship. Now the surgeons do 1 year, but I did 2 years because I didn't know what the heck was going on. There was really no recognized specialty of critical care medicine. And just before I ended the second year, I was already, being used as a staff member to make rounds about half the time in the month. So, and stayed on the faculty for about another almost 3 years. So I managed meanwhile to get my board certification in general surgery and was hoping to go back into a combined career. That didn't happen. So eventually I ended up doing critical care full time and had a good opportunity to come back to Detroit in a different hospital where I had trained. And that also happened to be I think, first ICU, which was to be managed by a formally trained intensivist. So within about a year, by 1980, I had set up the first fellowship in the state of Michigan. And for several years, about half the people trained in the state were from our fellowship program. So I'm quite proud of that program, which lasted about 10 years before I had to move to another community hospital in suburban Detroit area, Providence Hospital. I spent another 14 years there, and I decided to retire rather early. So I really haven't done full-time work since about in ICU since 2003. Did some part-time work till about 2007. So I'm an old man.
So that was wonderful, and I took two things away from it. Number one, you too went into critical care as a default, just like your son, and and number two, who doesn't want to go back to Detroit?
That's
I think
right.
it's what we all aspire to do is someday move to Detroit. So that's
Yeah.
awesome. That's wonderful. And I think
Yeah.
there's so many gems probably hidden in that. Let me ask Nathan. Nathan, where do you think we should go with this? What you know him the best. What is maybe I'll have you kind of ask your favorite story that your dad, you remember hearing from your dad over and over again from the ICU.
Our dining table conversations were always sort of unusual. We always had dogs while growing up, so there was always like end of life conversations about dogs. Like they're getting old, dogs are treated better than humans. Humans are made to suffer over a long period of time. But I'd be curious to ask Papa about you always talk about Max Harry-Weil, and that's the person we hear about all the time, but you won an award years ago, the Shubin Weil Award, and we never hear about Shubin. Can you talk to us about him a little bit and your time in California under him?
Yeah, I was fortunate to know and work with Herb Shubin. In those days, cardiologists were actually called cardiopulmonary specialists because there was no pulmonary specialty. So Herb Shubin was known as a cardiopulmonary specialist. He was Canadian but settled on the West Coast, about the same age as Hal Weil, and actually in his younger days had played semi-professional ice hockey in Canada. But he was a wonderful and gentle person, very knowledgeable, very agreeable, it was unfortunate that by about the second year of my fellowship in 1976, he was skiing in the mountains in California, and he died of a massive heart attack. But if you see the original publications from Hal Weil, so there always is a, you know, Herb Shubin's name in all those publications. And he and Dr. Weil set up this foundation, and the Critical Care Excellence in Critical Care Award, which I was fortunate to get it in 1994, under the aegis of the Society of Critical Care Medicine. So it's a SCCM award. And so that was Herb Shubin. Uh, I, I think those who got to know him admired him. And I have to admit that in comparison to Dr. Weil, his personality was very gentle and not so demanding.
So, so, Dr. Puri. Actually, you know what? How about we do the younger Dr. Puri? You mentioned something about uh, dogs getting taken care better of than humans, and I can't let you go with that comment. And I believe Dr. Kevorkian practiced in Michigan. Is that correct? And
Yeah.
maybe I'm incorrect. Did you know him, or do you have any experience or practicing at the same time?
No, actually, Kevorkian was a pathologist. He was not a uh,
Hmm.
clinician, uh, didn't practice any clinical medicine. Uh, he's rather a quirky person by personality. Uh, and he made up his homemade machine, make you breathe carbon monoxide, and believed very strongly in euthanasia. He even wrote a book. But for that person, the state of Michigan ended up passing a law just to target him. And the poor guy spent about 8 years in prison after according to him, he had helped, I think, maybe around 38 people die in the back of his van. So it was very poorly executed euthanasia program. Uh, and little footnote is that he was also fond of, I think he had never married. He had a sister. He he also painted some very gruesome paintings, and I don't know, they became famous after he died. Uh, I think in his defense, I'd have to, just quote uh, my friend and former president of the society, Richard Carlson, who was at the time chief of critical care at uh, Wayne State University. Uh, he said, I don't think what Kevorkian did was right, but I hope if I need him, he's there.
Mm.
Yeah, that's
And
pretty
So I
pretty
think,
wise.
right. So I
and
think uh, I don't think we are anywhere near, especially the state of New Jersey where you guys practiced. I think your laws were changed about brain death many years ago.
Hmm.
And so I think it's unfortunate that what we end up doing to people who are defenseless and lying in bed there, uh, I'm mostly talking about sort of the terminal type of thing, the CPR, the sticking tubes uh, into them. Uh, Most of the people don't know what we are doing to them, and they never ask for it.
Yeah.
And
Yeah.
many times we know the outcome of what we are doing,
Yeah.
and yet we do it. So
To-
I think, go ahead.
I just want to ask a quick question because what you're saying, I want to build on that. And
Yeah.
for those of, we may have some very, very young listeners on here, young meaning, not knowing who Jack Kevorkian was, but I certainly knew who he was. I think he was in high school or college when he was really gaining fame, not the kind of fame he wanted. But for those of you
Right.
who don't know, this was a physician, a pathologist. I actually didn't know he was a pathologist, but kind of makes sense when you said he has a quirky sense of humor. But he was a person who at the time was making a system available for people to take their own lives who had terminal illnesses. He would screen them very carefully, and he would set up a device where he would basically tell them what they're doing and let them make the decision as to what they want to do next.
Right.
So he was helping to facilitate their end of life care. And for me, as someone who was interested in going to medicine, I thought this was truly amazing because seeing people that I knew die of terminal illnesses in a very painful way, it only made sense to me that this was an option and why weren't we doing this? And so when I came into medicine and seeing people, spend their final few days and weeks in agony and pain, and then having to, in my opinion, inflict some of that because families had wanted that. What he did was very touching, and it gave me perspective. And so I just wanted to give people perspective on who Kevorkian was. But I also wanted to ask you, at that time, whether or not you fully agreed with the way he executed, that's probably the wrong word, with the way that he implemented his practice. What was the general sense of the medical community, people who were in medicine at the time? Did they feel as though what he was doing was valiant? Did they think that it was poorly planned? What was the vibe? What were people talking about at that time?
Yeah, I think it mostly was, even those of us working in ICU sympathized with him or his ideas. It was just so poorly. He had an old beat up van, and he'll go and park it in some parking lot. There's a place in Detroit next to the river called Bel Air. So he would even sort of go and park there, and uh, and have this take place, then essentially end up dumping the body in some hospital or something. So I don't think it was anywhere close to the Nordic countries model of euthanasia, or the Dutch experience. So I think most people were disgusted because there was such lack of dignity, uh, that yes, he fulfilled the desires of the families and the patients, but it really was, uh, I think, just mechanics were really very, very disturbing.
And the last question I'll ask you, and I'll turn it back over to these guys, is do you think it was the way it wasn't carried out all the way through with dignity? Is that what led to the public uproar at that time? Or was it just that people were not ready to deal with this concept of people making a decision to end their own life?
I think the church uh, was definitely very much against it, and most politicians would not commit to that kind of procedure. Uh, so I think the later changes we saw in starting from state of Oregon and other Western states, they probably, I think they were, with the safeguards built in, they probably are more acceptable to the public.
Thank you.
Yeah, that's fascinating, and I think we could probably talk about the ethics of providing care, especially in patients who have high mortality. In light of the COVID pandemic, I think we could probably spend in multiple sessions just talking about that. Um, but I was thinking there's something else you mentioned about your career that I think would bring in an interesting discussion. And you had the opportunity to both practice in a university center and then also in the community center. And I think this is so interesting because sorry, I currently work at Cooper, but then we also work in some more rural community hospitals. And I would love your take on this. I think that there's this perception that university hospitals is the pinnacle of care. It's the hardest. You see the sickest patients. And I will tell you, when you're out in the community, your resources are less. There's less people around to help you. You have to rely a lot more on your own um, intellect and diagnostic skills, etc. That I find those days are by far the hardest for me. And I was just interested in your perspective and your career and how you dealt with that.
Uh, I certainly agree with you, and uh, just want to mention an insight, and Nathan knows about it. Both emergency medicine and critical care actually were developed and evolved in community hospitals. Of course, teaching community hospitals, uh, but not so much in the university hospitals, because the university hospitals found these so-called specialists uh, a little hard to take. So they came sort of joined the movement later. Even the unit where I trained in Los Angeles was located in a community hospital. It was called Hollywood Presbyterian Hospital. And uh, it was a university unit located in a community hospital, which had no other house staff except the critical care fellows. So you can imagine the kind of scut work we had to do because we wanted patients in the ICU, you know. Uh, so I think now, of course, most universities have joined this trend. I think both these specialties had to prove themselves that they could produce basic research, publish it, and go for the evidence based medicine in order to survive and be recognized.
So I don't mean to pry, but when your son decided to do a pulmonary critical care fellowship, how did you feel about that decision? Did you say to him, "Why don't you just do a critical care fellowship? Why are you wasting that time?"
Actually, I told him that. I said, if you like critical care, because after he did his pulmonary fellowship, I asked him once in a while, I said, how many bronchs do you do? And, he said, oh, no, I'm doing bronchs.
Boss
But
man,
I
how does
think
that make you feel?
well, I wish I had a better opinion of this pulmonary critical care fellowship, but I don't from experience. Majority of these people want to continue to have office practice. They want to have
Right.
sleep apnea experience. They want to call themselves allergists. Some of these designations of professors, I see them and I say, what has that got to do with critical care?
I should have told
So,
you that I'm a pulmonologist as well, that I trained pulm crit care. So I,
no,
uh,
I have a great deal of respect like Phil Dellinger. I think even if he had pulmonary background, he pretty much gave it up. And I think if you guys have given it up, and yet you have the knowledge of the pulmonary physiology, which I had to learn in very difficult ways. Uh, I think I admire you guys that if you're sticking with critical care as your essentially probably close to 100% of your practice, then you're okay.
That's great. That's great. Hey, any questions off that or?
No, it's always a sticky subject when you talk about pulmonologists in critical care, because
Right.
residents or I should say residents and medical students ask me, what's the best route to critical care? And that's the first question I ask them. I'm like, are you interested in doing outpatient stuff? They're like, no, I want to do critical care. I was like, then you need to take pulmonology out of the conversation, because in my opinion, and I honestly don't care if there's flack for this, if you're going to do a pulmonary critical care fellowship, you're only spending 6 months doing critical care, maybe a little bit more with electives, versus 2 years of doing critical care. And if you ask day one who's leaving as a better intensivist, I think, the answer is clear. Does that catch up over time, over the span of 10 years of a career? Probably, but I think it relies a lot on the individual to how much they're going to spend in the intensive care unit versus, having their preference to really just do more outpatient practice. But it's really, actually, I should say, really refreshing to hear that perspective, because I would have thought, just, assuming that that Dr. Puri would have maybe said that that's like the best way of doing it, because it's the classic way. So it's really refreshing to hear that that we think the same.
No,
Yeah,
I
I would.
think, I think
Go ahead, you.
after internal medicine residency, 2 years of critical care prepares you quite well for the practice of critical care.
How do you feel about emergency medicine now becoming part of critical care?
Now that's something new, and I hear, you have some very well qualified people on your staff. So I have to be careful of what I say.
No, it's just us on here. No one else is watching, so you can say whatever you want to say.
Uh, I used to get ER residents rotate in the ICU with me for a couple of months, and actually I found them very good. They were good with their attitude, they were good with their hands, and so as a surgeon, being good with your hands is important.
Yeah.
Uh, so I admired them and liked them, and I even had a fellow who's actually chief of critical care at one of the hospitals in Detroit area, who had done 2 years of uh, emergency medicine, and he decided to, do critical care. I told him, and this is 80s, that it's going to be difficult for you to find a job. So this poor guy ended up going to Wayne State University locally in Detroit. And after doing 2 years of fellowship with me, having to do internal medicine residency. And then subsequently he did well. But at that time, we did not recognize, emergency medicine having very much to do with critical care. Uh, I I think with the ER, you're probably getting close to the Spanish model, where right out of med school you end up going into critical care and you spend 4 or 5 years, and so you probably learn a lot of different things.
Yeah. Yeah, just I'll just throw this out there. Just, I don't know if it's time to move on, but one of the Randy, who's infamous on this broadcast, says this discussion is designed to anger. So I don't know if he's a pulmonologist or not, but it's always, if you know Randy and you know these streams, he's always got something good to say.
Yeah, that's right.
Um,
So Haney, one thing I was going to say, I'm going to pivot a little bit, and I'll say I don't think there is a best correct route to critical care, and I actually think it's what makes our department at Cooper so strong. And I think that anyone who's designing a critical care group is you would want to pick from all different backgrounds. I think that's this idea of multidisciplinary critical care, where yeah, maybe you have an ER doc, maybe you have just an internal medicine, maybe you have someone who's nephrology trained. I think it just brings a little different flavor, and So I don't know, Nitin, if you have any comments on that. I don't want you to sit here and say nothing the entire time.
No. I'm just enjoying the conversation. No, we're strong believers in multidisciplinary critical care, and in reality, my father is a surgeon who ran a medical critical care fellowship, and you can just imagine the perspective that the internal medicine folks got from a surgeon teaching them. And I've learned so much from people from different backgrounds, and it's part of the joy of practicing medicine. And I actually think the patients, it's never been studied, but I got to believe the patients get better care, right? Mm-hmm. Because you are able to be like, hey, my colleagues who's a surgeon say, hey, listen, what do you think? How should I handle this wound? Or you can make a phone call to the ID critical care doc or the nephrology critical care doc. I can say for myself as a pulmonologist, those years made me a better doctor, just learning physiology, thinking. Papa, what do you think about multidisciplinary critical care? Is that your mantra?
Oh, absolutely. I believe in it. And I have to tell you, when in the initial 70s and 80s, most of the general surgeons really didn't think that there should be any intensivists in the surgical ICU. So, because they said, no, our residents are capable of doing everything. I, on the other hand, felt very strongly that having trained with cardiologists and having trained with pulmonary people and internist, I had gained a great deal. And I remember writing a letter for Archives of Surgery that it is all right if you want surgeons to run your ICU, but what happens when your resident increases the PEEP and then goes to the OR for 8 hours? He's scrubbed there. What happens to the patient? Who's looking after that patient? So I never got an answer to that. So I think it's the time you spend at the bedside is very important.
So I'd ask you, from the days when you're talking about starting the first intensive care unit in Michigan or the first fellowship in Michigan, to now the days of the pandemic, where in reality the world, the countries that are wealthy enough to have intensive care units leaned on them heavily. Could you have ever imagined it the way it's grown?
Well, I am in awe for all of you. I think how you guys have managed to stay with it and uh, and not just manage your ICU and ICU patients, but also manage your personal lives. The stresses have to be very, very hard, and I think there have been some descriptions in the newspapers, like New York Times, about what the intensivists do, or but mostly it's been about nurses, critical care nurses. So I wish the public knew a little bit more about what all of you have faced and handled yourself so well that I am full of admiration.
Thank you.
Thank you. Thank you. I have a question. I've just, I'm only 5 years into my training, and I think about what has changed from when I was a resident to now. And the example I always give, that when I tell my residents or fellows blows their mind, is that we checked an SpO2 in every septic patient, and if it was low, we started dobutamine. That was just what we did, right? Unless, of course, they had AFib, then we stopped. But we always did it. And so I'm sure you have something to say about SpO2, but what I'm more interested in is, was there something similar during your training or during your practice where new literature came out that dramatically changed the way you practice. I'm just curious as to what that was.
Uh, yeah, I think we were very excited when these SpO2 monitoring uh, opticats came about, uh, and continuous monitoring always is better than the periodic kind of observations. Uh, but unfortunately, it didn't figure out. I hate to be technical about it, but I realized that the SvO2 monitoring was essentially based on playing with the Fick equation, and which had other things such as hemoglobin, oxygen consumption, uh, cardiac output. So, of all the variables, if they are unstable, how can you depend on one variable in order to tell you about perfusion? So I think that came about. Uh, it came and went. I think there was the period we had of something we used to call super PEEP. Uh, there were people, especially from Florida, uh, who essentially had this mantra: higher the PEEP, better it is. Uh, it never seemed to work out, at least for us. Uh, so there definitely, I think the struggle in the 80s of this optimizing oxygen delivery, I think that's probably where the dobutamine to increase cardiac output came up with. But I think that eventually proved to be rather a false notion. I have to admit that worked very hard trying to, prove something, but it never worked out. And uh, I think other big controversy which I had quite a bit of personal involvement with and experience was this crystalloid colloid resuscitation controversy. Uh, Now it appears it's almost settled, but that's okay. I happen to be in the colloid group because Dr. Weil had also invented something called an oncometer to measure colloid osmotic pressure. Uh, but I did get initially at least to publish some data on HESPAN, hydroxyethyl starch. So, no, I know that didn't work out eventually very well. It's probably not that great a fluid, but these changes, they come. You sort of deal with it, I guess, and then move on.
So all I have to say is, when you mentioned oxygen delivery, could you imagine where we would be if we didn't have all those pulmonologists in the ICU at that time? I'm glad we had someone there who knew what they were doing, right?
Yeah, that's true.
Well, and
So,
the other one is activated protein C.
mm,
I mean, Zygros was a huge drug at
Right,
one point,
right.
and
Oh,
that just
absolutely.
sort of spun in the way we controlled blood sugar. I mean, there've been many things that have
Right.
changed dramatically.
Niceratide, remember, wasn't that a thing too?
Yeah,
Niceratide for a while.
Niceratide was a big deal. I mean, we've definitely gone through, and we really didn't have anything that worked for ARDS. I mean, until low tidal volume ventilation, but proning, and there's controversy now in paralytics, whether to be given or not. But just it's been significant changes over the years in the practice of the critically ill.
Can I ask a question? Dr.
Sure.
Puri, of the things that you have seen when you were first starting in critical care to what you're seeing now, can you think of something that has come completely full circle? In other words, is there something that when you were starting out or getting settled as an attending physician, something where people are saying, this is what you should do, and then it went away because they say you should not, and now it's coming back? The thing that comes to my mind is cap refill. Because it was one of those things where when I was coming into it, the physical exam, I'm maybe ashamed, maybe I'm not. Ultrasound was coming to be more pronounced, and so we were spending less time doing a pure physical exam and more time looking at the heart and looking at volume responsiveness. But the Andromeda trial came out not too long ago and said, well, cap refill is actually even a better marker. So I don't want to distract from the question. The question I have for you is there something that you can think of that is just so palpable where you just saw everything come again full circle?
Uh, I don't know. I sort of not big fan of capillary refill because, you know, one person's capillary refill may be equivalent to another person's dirty nails.
Or
So
nail
I
polish, right? What do you do if they have nail
that
polish on?
too, or just being brown and or black. Uh, I think it's when we mentioned my guru, Dr. Weil. He had a very simple adage: if you can put a number on something, it becomes solid, and you can always depend on it.
Hmm.
Now, is there? I mean, if I see the capillary refill in 5 seconds, another person sees it in 6 or 7 seconds. Uh, you'll have to decide who's right, who's not.
It's like
Uh,
xanthochromia, right? In the lab, when they do it, they just hold it against
yeah,
a piece of paper, and the
right,
lab
right,
technician's like, what do you think?
right,
Yeah?
right. So I think that's why, uh, I think at least in shock, something which uh, it talked with Adam a little bit, or Nitin, is it, about something called toe temperatures, toe ambient gradient, which is non-invasive and be measured very easily and doesn't cost a penny after you buy cheap thermistors. Uh, it probably wouldn't work in other conditions except in shock. But in shock, you can correlate it to lactate, you can correlate it to cardiac index, and even survival. Uh, I have, I have used it. I still probably have an unused machine in my garage. I gladly gift it to you.
Yeah, we'll take it. We're short on
Oh,
supplies these days, so.
okay.
Is that toe temperature, just as a curiosity? Because one of the things of the few physical exam things I do when I'm seeing a patient in shock is I actually do feel the feet to feel the type. Is that as simple as doing that, or is the toe temperature something that's much more specific, much more focused than just
No,
a
it's
gross?
it's much more specific.
Mm.
If it's, uh, I think it's if the difference, and it has to be the difference between the toe temperature and the ambient temperature.
Mm.
So
I
you,
see.
you also need a rectal probe for central temperature and, thermistor on the great toes. Uh, but I think that's definitely something I encourage all intensivists, uh, that in very Indian and Hindu tradition, to go and touch their patient's feet. Uh, Cold feet are probably never a good sign. And I think when you look at the toes, also look at the kneecaps. Uh, if you find the kneecaps blue or purple, that's bad news. Uh, so that will tell you that there is a perfusion problem.
Very, very interesting. Well, that's good to hear that I'm doing at least one thing right. So thank you.
Yeah. No, that's very, very good, very smart.
Sorry, I got kicked out for a second there. How can I ask? I don't know if you mentioned it. How about the PA catheter? Should we be putting more of them in?
Well, I've always asked Nathan, and he tells me that you guys are still putting PA catheters. Uh, I am sort of not a big fan of depending on mean arterial pressure, CVP, and essentially running up your vasopressors, especially norepinephrine. Uh, in our days, we really didn't think that norepinephrine should be used at all. Uh, but there certainly is a role for it, but within limits. Uh, but now I hear some of your patients may be on vasopressors for 1 week, 2 weeks, 3 weeks, and that bothers me.
Hmm. It bothered. Let me ask you this then as a follow-up question. Do you think we focus too much on numbers and less on how the patient is doing? In other words, are we looking too much to get to a map of 65 rather than looking at the general picture of urine output, warmth of the feet, organ perfusion, those types of things?
Right. That's the reason for.
Yeah, I think Mervyn Singer, he was one of the people when I first got into critical care who I just admired so much. He's just this, for those of you who don't know, he's just this boisterous British guy. He's just an amazing lecturer, worth a listen. But one of the things was his big things is that we focus too much on the map, and we focus too much on these numbers, and we're not taking a step back and saying, why are we trying to achieve a number if the person is telling us physiologically that they're doing very well? And it sounds like you're on board with that as well.
Oh, absolutely.
Great. So I have one more question. Actually, I would like to ask all three of you because I think it'll be interesting. And the question simple is someone who's thinking about going into critical care, what's the advice you give them?
I I would advise them that uh, it's a great career. Go in, but also think about that you're going to stick with it, and not go into a tangent within a few years' time, because then you really are taking that opportunity away from somebody who may be more dedicated than you. Uh, and my way of thinking of critical care was that it's a full-time job, it's a salaried job. You're not going to be very rich. No, you guys are rich, that I know. Uh, but there's a lot of satisfaction in it. I think satisfaction of dealing with human beings, having to deal with difficult families many times, and you see the physiology right in front of you changing. That's a great way to gain knowledge. Uh, so I think those probably motivations are much more important than getting simply a title that you are critical care specialist.
Perfect. Well said. Well said.
Boss, what would you say?
Uh, First, I'd say come to Cooper. We'll train you up. But I also would say it is it's just an opportunity to make such a dramatic impact in somebody's life in such a short amount of time, and that people will remember you forever.
Well, I don't know about that, but I've been quite happy with my academic uh, accomplishment or whatever it is. Not a great deal, but and I managed to know many good people, including Phil Dellinger, by the way. He's a great guy. He's a very good teacher, very good investigator, and he deserves a lot of credit for shaping the career of many of you. So hats off to him.
Fantastic. Fantastic. Well, I can't think of ending on a higher note than that. Dr. Puri, Dr. Puris, thank you for being here tonight. It's, it's really been a tremendous honor talking to you. Nitin talks about you quite often. So for me personally, it's really been a pleasure to meet you and hear where you came from and your perspective on how medicine has changed and hopefully where we're going in the future. So thank you for taking time out tonight to be with us.
Well, thank you. Thank you for inviting me.
Truly a pleasure.
Appreciate
Truly a
it.
pleasure.
It was wonderful. Thank you so much, guys.
Bye.
You guys have a good evening.
Bye.
All right, Adam. Another one in the books. That was fun.
That was wonderful. I liked it. I thought it was really good. It's just so interesting, right?
The perspectives that we have are so local. We have access to the people who are just like a couple years ahead of us, right? And so we're hearing their perspectives. But to hear his perspective about, he was there with the giants. He, he's probably too humble. It's probably one of the giants himself. And to hear where critical care has come from, to start a program, and then to hear what he thinks of critical care today, just fascinating. Fascinating.
Totally agree. Agree.
Yeah. So, Adam, we were talking a little bit today. Do we just go out there and say what we're going to do on the next show, or do we wait to finalize it?
Let's do it.
You want to do it?
Let's spill it.
It's your idea, so go ahead.
Yeah, so I'm going to keep it vague because, we like to drill down up and coming, right up to the show. But I think we're going to talk about hypothermia, and I'm going to leave it as simple as that. Not treatment of hypothermia, not what you do when you fall in a lake, but rather, when do you make your patient hypothermic? What do we think about? What are the applications? And we'll leave it at that.
Yeah, I think this is one of those topics that people think that the book is closed. And some people think the book is closed, but there are other people that aren't so sure in light of the recent trials. So we will be talking about therapeutic hypothermia, and we have some special guests that we're reaching out to. So let's not make ourselves look bad when those guests say no, but I think we're going to get them on. I think it's going to be a great show, and we'll do it in 2 weeks' time. And I'm also very, very excited because we're getting very, very close to live Critical Care Lounge. So I think this is a good opportunity to start getting people ready for it and let you know what exactly we're thinking about. What I'm thinking about is we'd like to do this in front of an audience. It'll still be available for those of you. Where'd that music go? Let's do a different song. Oh yeah, there we go, Adam. Here we go. All right. What I really want to do is I want to get up in front of people. I want to meet whoever's in the audience. I really just want to meet Randy. And I want to do it in a place where we can all get together, have a little wine, a little cheese, some appetizers, and then we do the show. For those of you who can't make it, we still are going to stream the show. We're going to be doing it just like this, but we're going to be sitting next to each other. So you're still going to get the virtual experience if you can't be here. You'll still watch it on replay if you can't be there live. But if you're in the Philadelphia, New Jersey area, it'd be great for you to come down. And I have a little space in Collingswood with a lot of seating, great lighting. That'll be a lot of fun, and we can drink and be merry, and it'll be wonderful. So that's going to be coming. Again, I don't want to overpromise, but let's just say in a month's time, we'll be able to meet in person, hang out, and do that. So if you're in the Philadelphia, New Jersey area, South Jersey, Collingswood specifically, please reach out to me and I will get you more information. We probably should set up a mailing list so that people can just get in touch with us and we can send out like little newsletters. So we'll work on that. And here, there's a question from the audience.
And I should say, and we should say, Andy, that this was always the dream, right? The dream was always to really mirror a lounge, not to sit in our own homes and talk. So
not our
I think
own
it's
lounges,
yeah, that's right. I think it's really exciting. I think it's really exciting.
It's going to be a lot of fun and mostly just a good time. We're going to have live Q&A. So stay tuned. It's coming. Like Adam said, it was always the dream. And where will the pizza be from? That's a great question. I would like to have it from Angelo's.
Are you volunteering to pay? Well, it's wherever you're picking it up from is what I'll say.
Exactly. Right, Adam? Right. What kind of budget do you think we have here? This wall isn't even real behind me. That's how low budget we are. No, don't worry. We'll take care of you. All right, people.
So
go ahead.
I think we should end the show where we started it, and that's about James Harden. So
Yes.
update.
Wait, hang on. Let's go.
Update 12. Oh, what do you
Wait,
got?
I just want to get some song, like the right kind of music. Actually,
No,
no,
I'll wait.
Hang on a second. This is going to be worth it. Okay. We got this. All right. We're talking about James Harden. All right, go ahead. Let's talk a little bit about James Harden.
So Knicks versus the Sixers right now. 12-7 Knicks. James Harden. Donut.
First of all, the fact that the Knicks are leading anything is a disgrace because, as we were talking about before the show, I'm a huge Knicks fan from growing up, and I'm ready to transition over to be full Sixers. Now they're starting to win. Now they're starting to play well. Don't worry. Yeah.
They just had to hear. There just had to be a whiff that you were going to change teams, and then all of a sudden they plummeted. You did this, Haney.
Maybe. Well, whatever. I don't know. I don't know what to say anymore. I'm just happy that Ben Simmons is over there and James Harden is over here. And this year, I think we're going to go to the Eastern Finals and maybe, just maybe, the title. Just throwing it out there. All right.
Wonderful. All right, everyone.
Let's get some outro music. People, good seeing you. Have a safe 2 weeks. We will see you back and talk about some therapeutic hypothermia. Have a good night, everyone.
Stay warm. Stay warm.
Yeah, stay warm. And we'll get cool next time.